So hello and welcome to another edition of the Osteopathic Lyceum podcast. We have Ashley Pehar, who is you hold an MOMSC, so you're an osteopathic practitioner. You also is the proper title CEP, Certified Exercise Physiologist. You're not a
Correct.
CSEP, you're a CEP.
Well, it's through CSEP,
Okay.
right? So CSEP would be the association or organization, and
Mhm.
then within that, I hold the designate with that association, I hold the designation of CEP.
Okay. Now, is there a designation CSEP? Is that actually a designation or is that just the organization?
That's just the organization.
Okay, that messes with me only because so if I'm not mistaken, you and I were both at York University at the same time. Because when did you go?
2005 to 2009.
Okay, so I was from 2000. I was part-time most of the way, so I was there until '08. So we definitely crossed over. And now, is it fair that Norm Gledhill was the person who essentially spearheaded CSEP?
I believe so. He was
Okay.
heavily involved with Ronnie Jamnik as well.
Yes. So I think, am I wrong? And maybe you don't know this. Was Ronnie working in Norm's lab?
Yes.
Okay. Okay. So that's
Yeah.
kind
And
of
then
how that went.
she took it over as he retired. Yeah.
Yes.
Yeah.
Yes. No, he is relatively well known if you know who he is for hating first year students and like saying that he does in the big first year lectures. He said he didn't say this when I was in there, but he did. I'm aware that he said this to people because they've said it to me that 50% of you will be gone by next year. Like you're just going to drop out.
I
So,
don't specifically, I did have him in first year. I don't
yep.
specifically recall him saying that, but it's possible.
Yeah. Well, you would have had him and Malzecki.
Yes, Malzaki, yeah, as
Did you
well.
know that Malzecki passed away?
I didn't know that.
Yeah, he
No.
passed away probably about 2 years ago now. He was a very, very interesting man. He and I had a few discussions, like outside of the class, and part of it was because he was from Detroit and my dad was from Detroit.
Okay.
So I saw him once running between buildings, and he had like some fancy Oakley sunglasses, and he saw me, and he turned around while still running, and hey! So Greg was an interesting man.
Yeah.
Norm Gledhill, people just to as fleshing it out a little bit to understand maybe the stuff that leads into CSAP and Certified Exercise Physiologist. He was very, very interested in physical testing for workplaces.
Yes.
So if anybody is aware of the prep test or the physical readiness evaluation for police, the structural and forest firefighting physical tests, at least within the Canadian context. He was heavily involved in those. Now, again, the way that any lab would work, it's not one person doing it, it's many people, but you have the person who's in charge, and that would have been Gledhill. He claimed that he would have liked to have had way more physical testing for way more jobs, right?
Mhm.
It would have been interesting to him. It would have been lucrative because he could have created the tests, right?
Yeah.
He wouldn't have said that specifically, but he was a little annoyed when I was in class in 2000 talking about how the government was kind of in the way. And I think you're only allowed to perform physical testing for a job if you can prove that if somebody didn't have a baseline physical fitness, that there would be possible or actual damage to property or life, is my understanding of it. So yeah, he also his lab handled the NHL entry draft testing.
Yeah. We were involved with that in my fourth year.
Yeah. So you actually went to the hotel
No,
and
I
did
was
some
at the
testing?
NFL Combine or NHL, sorry, not NFL,
Yep.
NHL Combine, and we did a lot of the testing for the firefighters as well.
Nice.
Fourth year, and
The
a little bit after graduation as well. I would go back and help
Sweet.
in the lab. Yeah.
Now, what I heard him say, and you might have some insight into this, is the way that they developed some of those tests, especially the prep test, is that they would bring cops to York University's campus, hire some young people, and just have the cops chase the young people around York.
Okay, I didn't know that, but
Yeah,
that's
well, they had to figure out a baseline. So it's like, okay, which cop can catch the perp and which cop
uh,
can't.
okay.
So what they would then do is they would put them through, as far as I understand, a battery of physical testing to identify where the cop who couldn't catch them was and where the cop who could catch them. Like you really just want to see where the cop who could catch them because it's like, okay, you have to be at least this, right?
Hmm.
So you're
Hmm.
looking at the delta or the degree of difference between them. So yeah, that's what I heard. I have no idea if that's the case, but yeah. So
Wouldn't surprise me.
yeah. Okay. So at York. there is the athletic therapy stream, the sports management stream, and the CEP stream.
Mhm.
Because I always I knew there was three, and I never remembered what the third one was out. I always knew sports management and athletic therapy were there. I'm like, what's the other one? There's some other one.
Yeah, it was like certificate for advanced fitness testing
Mhm,
and
yep.
counseling or something.
Yeah, yeah, yeah. Oh, also when people go into the gym, if people go, I don't know if this is international, but it's definitely in Canada. Anytime you go into the gym and you have to answer that small questionnaire, the PAR-Q,
Yeah,
uh, physical activity readiness questionnaire. So it's like
yeah.
if you answer the PAR-Q, basically, if anybody's ever done it, which most gyms will use it, just it's a liability deal. The answer is the proper answer is no to everything, if I remember right.
Well, yes, because ideally, like what falls within the scope of practice of most personal trainers are a healthy population, and that's what
Yes.
differentiates the CEP is that
Mhm.
if someone checks yes to some of those questions,
Yeah.
that then would fall to a CEP, and then we
Yeah.
would have the ability to train special populations.
Mhm. Yeah. So and if you don't, and the Park Q again was spearheaded by Gledhill.
Yes, and that's still today like maintained by CSEP as an
Yep.
organization, and they put out all the physical activity guidelines and
Yep.
up.
Yeah. So, okay, you chose to pursue CEP.
Mhm.
Okay, and that was concurrent with your degree. You did was yours a BSc?
I ended up doing a specialized BA in canon health science.
Okay, yeah. So this is another thing that
It's mainly
not
because my first 2 years, I didn't have all the sciences and maths I needed. So
yeah. Well,
all my upper year courses were equivalent. Yeah.
well, one of the things that is mildly unique within the Canadian context about York University's kinesiology program is that you have the opportunity to get a Bachelor of Arts in Kinesiology or a Bachelor of Science in Kinesiology. The core kin courses are exactly the same. They're science,
Yeah.
right? Or they would be considered science. Whereas it's your elective courses that would differentiate the BA and the BSc. So I have a BA. Like I just have, I think all BAs at York are considered honors BAs because they're 4 years.
Yeah.
Right.
Yeah. That's
Whereas
true.
say Mac at least used to have 3-year programs, 3-year bachelor programs. So you'd get a regular honors versus or sorry, a regular bachelor's versus an honors bachelor's. So there's a lot of quirky stuff between institutions. But yeah, you took some psych courses. Well, everybody had to take psych. So you would have taken like, some English courses or something like that.
Yeah. I did more like some social sciences and
Yeah.
things like that. Yeah.
Yeah, yeah, absolutely. So the process for getting the CEP at York, there was specific courses that you would have taken, which would have probably been like physical testing courses.
Yeah, I mean, I don't recall the exact courses, but there were specific requirements. So it was kind of, I did it mainly in my fourth year. And then
Okay.
there was, the lab requirements
Yep.
as well, and the testing requirements, like, like I said, with the firefighters and
Yep.
yeah.
Yeah, yeah.
Yeah. And
Well,
then we had obviously like a test at the end that was for the certification
mhm.
itself. Mhm.
Well, one of the interesting things about something like that is that the undergrad students are your unpaid labor,
Oh yeah.
right? Like you do all of the actual testing work, which I find really interesting because there's a level to which some bench work, like you'd call it bench work, or at least in this case, it was like field testing. You'd hope that there was a level of technical proficiency that maybe an undergrad might not have, but in most cases, the tests are likely straightforward enough that you're not going to screw them up too much.
For the most part, yeah, I think.
Yeah, I just find it interesting because there's an error in a lot of interaction with, say, scientific processes where people are like, oh, these like people are technically proficient. I'm like, listen to me. No. Like, just no. There's some people who are good, like, lab techs, and some people who are decent at that. But the amount of like messed up tests
Oh
that
yeah.
you have
For,
to throw
for
out,
errors,
or
yeah.
like you have to do again, or it's like, no, it is not this fantastically clean process. It's still done by people and it's messed up. And some of these people have no idea what they're doing. And then, and then the data set ends up in a paper.
Absolutely. Yeah. And
So,
I saw that later on through my professional experience. Yeah.
oh yeah. So, okay. So you get this certified exercise physiologist. Okay. And
Mm.
that's '09 when you graduated, correct?
Yeah.
Okay. So upon graduation in '09, you then went into working in that world. So what did you start by doing there?
So I initially started just as a personal trainer at a
Oh,
boutique fitness studio in Toronto, in
okay.
the West End. I did that for about a year until
When
I then went to Sick Kids. Yeah.
when you say West End,
Yeah.
okay,
Hyde Park.
now hold High Park.
Yeah.
That's okay. So here's the thing. I grew up in North York, right?
Mhm.
So there are certain things like somebody said East End to me the other day. I'm like, do you mean the beaches or do you mean Scarborough?
Fair, fair.
So High Park, sure, West End of Toronto proper,
Yes. Yeah.
fair enough. I'm like, no, that's Etobicoke. That's what are you talking about?
Yeah.
That's completely personal. Okay, so in and around High Park, so the term boutique does make more sense to me at that.
Yes.
The
It's
okay,
very Toronto shishi kind of.
yeah,
Yeah.
yeah. So then from there, so you were working at mostly as a personal trainer. Were you in a position at that space to work with some specialized populations, or was it more just people who were doing it for lifestyle?
It was mainly just lifestyle training.
Okay.
But I'd always been interested in like exercise for chronic disease prevention and management. That's kind of
Hmm.
always been my thing. So
Yeah.
that's kind of what got me interested in looking for opportunities within a clinical population.
Okay. So you, like you say, you did that for a year, and how did you end up at Sick Kids as a result of that, or not necessarily as a result of that after that?
Yeah, so a client of mine was a cardiac nurse at Sick Kids,
Mhm.
and I was training her and just telling her kind of what my interests were. And she told me about an opportunity, a study that was happening at Sick Kids, and she knew that they were looking for some staff. So that's kind of how I found out about the
Mhm.
posting.
Mhm.
So she just sent it to me. She didn't have any sort of influence whatsoever
Yeah.
over it, but she sent me the posting and then I applied. And that's kind of how I got in at Sick Kids. Yeah.
So the one of the things that it just brings up that I want to touch on, just on account of my larger world, the what you're pointing to is just having a good extended network of people, right? Just
Mhm.
having a good extended network of people is how things actually work. The idea of being on a bunch of online job boards and applying and all of a sudden the serendipitous thing happens. It's like, no, it doesn't really work that way. The person tells you, right? Now, as you know, she didn't have any specific influence over you getting the job, but when a person tells you, it's usually a better lead, right?
I think so. That's been my experience
Yeah.
throughout, various opportunities in my
Yeah.
lifetime. Yeah.
So at Sick Kids, what was your role?
So at Sick Kids, I was a project coordinator
Mhm.
on a study looking at physical activity in children with varying levels of congenital heart disease.
Okay.
So, yeah.
The so the in that project coordinator, you said project coordinator, right?
Yeah.
Okay, in that role, you weren't terribly hands-on on the research side.
Um, what do you mean, like in data collection or?
Yeah. So as far as data collection or running some form of experimental protocol, you were more hands-off there.
I would say I was still fairly hands-on.
Okay.
So it was essentially just myself and a research assistant that ran the
Mhm.
project.
Okay.
Uh, yeah, so it was a study of about our recruitment goal, I believe, was 300 kids from throughout Ontario.
Okay.
And so we were responsible for recruitment. We conducted all the study visits, which consisted of 4 different like visits throughout.
Mhm.
I think it was a year. Each kid had to be in the study.
Okay.
So it was once a quarter. We would meet with the families, and
Yep.
often we would travel to different cities around Ontario
Yep.
just to help with adherence because it's difficult for families to, we're recruiting from all over the province. It's difficult for them to come to Toronto. Plus, it was also quite frankly cheaper for me and my research assistant to travel
Yeah.
within Ontario to meet with 5
Mhm.
families in a day versus come and pay for 5 families to come and stay downtown
Yeah.
Toronto and
Oh,
meals
yeah.
and all that, right? So just from a
Absolutely.
budget perspective, it made more sense for us to travel.
Okay.
And so then we would conduct all the research
Mhm.
visits, which consisted of my research assistant would do like the gross motor testing, which was
Okay.
one of the main protocols. So they wanted to see that if the gross motor skills of these children would improve after the different physical activity
Okay.
interventions,
Okay.
right? So visit 1 was like a baseline, visit
Huh?
2 would be one or the other
Mhm.
intervention, which she was blinded to. So that was the piece that I was responsible for.
Okay.
So one of the interventions would be like a max VO2 test
Mhm.
that the
Yep.
parents watch their children do, because a lot of them had anxiety or fear around right around intensity, physical activity
Yeah,
intensity.
yeah.
And so the idea was that if parents could see what their children were capable of, that then they would be more comfortable in allowing their children to sort of push themselves and self-limit physical
Yep.
activity, rather than them imposing a limitation on their
Yep.
children. So that was one intervention. And then the second intervention was more of like a physical activity counseling session,
Mhm.
where I would receive information or directions from the child's cardiologist in kind of types of physical activity that that child was cleared for.
Yeah.
And then I would come up with different sort of ideas and booklets and resources within their hometown of physical
Mhm.
activities that they could participate in.
Okay.
So then we would sit with the parents and the children, and we would kind of talk about that
Mhm.
and go through
Yeah.
that. And then and at each visit, there would be different interviews that we would do with the children, one we would do with the parents, and of course the gross motor skill testing.
Yeah.
And then at the end, we would have sort of an end kind of wrap up, follow up
Mhm.
interviews, and
Yeah.
again, the gross motor testing.
Okay.
And then at each visit, they would wear accelerometers that would kind of track
Yep.
physical activity.
Okay.
Um, and then parents and siblings could wear it as well. So that was kind of the
Okay.
basis of the study. So we did all of that, and then of course collected all the data, did all the
Mhm.
data entry, and then cleaning, and then when it came to like we had a statistician that did all the stats, and then other staff that did the writing of the paper.
Mhm.
But yeah,
So
that's the process.
yeah, so the outcome measures
Mhm.
were change in gross motor skills.
Correct. Yeah.
And so the accelerometer, was that just a general collection for, say, variance in how much they moved, say,
Yeah.
along the way? Okay.
Yeah, so we wanted to see their minutes of physical activity as a whole, and then we
Mhm.
wanted to see how many minutes were spent in light activity,
Yep.
moderate activity, and vigorous activity, and
Yep.
how that data set compared to normative data for quote unquote healthy children.
Yep. Absolutely. Then were there any other outcome measures? Was there anything else that you were trying to report on?
This is like we're going back over 10 years, so
Yeah, yeah, it's
I'm doing my best. I don't remember. I don't
okay.
recall, to be honest.
And the
They're
only
pretty
reason I
updated,
ask is
but
because prior you were just noting something along the lines of the qualitative data.
yeah, and so there may have been in
Yeah.
terms of like attitudes. Did
Mhm.
attitudes change?
Mhm.
About physical activity, from a
Yep.
parent's perspective or from the child's
Yep.
perspective. That may
Yep.
have been like a secondary outcome measure.
Yeah.
I think it was a primary, but again, it's hard for me to recall.
Yeah. Well, depending on the nature of a study, it can be considered a quantitative study, but there's this interesting phenomenon for me where people think qualitative and quantitative are meaningfully different. Like they think they're meaningfully different. Whereas if you go to bedrock, right, a quantity is essentially a standardized, agreed upon way to report a quality. Does that make
Hmm.
some sense?
Hmm.
Right? So it's like you can have say a phone cord that's an inch long. You can have a shoelace that's an inch long. You can have a hair that's an inch long. So they all share the quantity, the agreed upon measurement of an inch. However, they are different. But if you're trying to talk about them, one of the qualities that they present is the same length,
Yes.
right?
Yeah.
Now, to really describe it, I need to go through other qualities. I can turn any quality into some form of standard agreed upon measurement that can be reported as a number scale. Like you
Yes.
can do
And
that.
that's how you analyze the qualitative data, right?
It's one it, so
It was
it's
one of the ways we did, but
it's one of the ways that people who like numbers are more likely to accept it,
hmm.
right? So yeah, you can do that. So there's definitely people who are like, "No, I'm a quantitative researcher." It's like you're just normalizing the reporting of something that happened. It's descriptive. Like just stop it. So the for me, the difference is not like it's not a meaningful difference. Like it's a meaningful difference in how you're describing it and what it then does to whoever's taking it on. But if you think you're one or the other, you're probably messing up.
Mm.
At least from bedrock, from things that you can't break apart any further, right? So quantities and quantities are just a normalized reporting of a quality.
Yeah.
It like maybe I'm getting sharper with that, or say there's less stuff, less extraneous stuff in that description. Anyways, okay, so you finished that up. Now,
Yeah.
was that a contract? So when that study was done, you were done?
Yeah, so I mean, it was a contract, and I worked for a very interesting cardiologist at Sick Kids, so I'm sure he's brilliant cardiologist, people person, not as much. So my contract was coming to an end.
Mhm,
Nothing had been said to me. My interest has always been in working. I missed kind of working with people one on one.
mhm,
The satisfaction that kind of I gained when I was a personal trainer of
mhm.
seeing people's improvement on an individual basis,
Yep.
much more removed from that in a research
Okay.
setting.
Yep.
So, because I hadn't heard anything about extension or new study to wrote me into, which ironically, when I went to put in my notice, he did try to pull me into another study, but I was kind of too late at that point. I kind of broke out on my own at that point and just did my own individual. I called it Fitness for Health, and I worked with people doing physical personal training and
Yeah.
like health kind of coaching, like
Awesome.
one-on-one. So I
Okay.
kind of ran my own business from there for a
Mhm.
little bit. Yeah.
Okay. And were you kind of located more in a gym setting? Were you going to people for that?
So I found a facility to rent. So
Nice.
yeah, so I was just renting space from
Yeah.
a different owner. I was bringing
Mhm.
people into me, and my focus was essentially people 40 plus who had some sort of health condition, health
Yep.
concern, orthopedic
Yep.
considerations, all of that. So yeah, I did that for a couple of years
Where were you doing that?
in Burlington.
Oh, nice. Where in
Yeah.
Burlington?
So like Applebee line, there was like a kickboxing gym actually. I got to know the owner there. I can't remember how I met him, but anyways, ended up renting space from him.
Appleby and where?
Like South Service Road, near the
Okay.
near the Applebee GO station.
Okay. Okay.
Yeah.
Mess with me a little bit. Well, that's were you on Mainway?
Potentially. So like, do you know
Okay.
Bay Area? Bay Area Athletic Club was the name of.
Yeah, okay. That I don't necessarily know that specific one, but that's awesome. Because it's something to at least point to because there are different personal training models where somebody's kind of a gym staff and they sell versus some places they'll do like an hour rental for a personal trainer. Like they'll
Yeah.
do that. And then
So
other places will do it in a different way because it sort of sounds like it was different than both of those for you.
it was so I realized like if I go back to just being a personal trainer in a gym, I'm not really a salesperson. I didn't
Yeah.
want to have
Yeah.
quotas to meet, and also then you're just getting your hourly rate, right? And
Yeah,
I'm
yeah.
like, I got a
Yeah.
mortgage now, I got expenses, so if I go out on my own,
Mhm,
it's a bit of a risk, but
mhm,
you obviously you can make a lot more doing that.
mhm.
And I wanted to work with a very specific population, so
Yeah.
then I had the ability to market to and kind of just
Mhm.
bring that population to me.
Awesome.
Uh,
Fantastic.
so that's what I did. Yeah.
Okay. So you did that for a while. You did note that you also ended up working at with Hamilton Health Sciences at the General.
Yeah.
You
Yes.
noted that offline. You didn't note that so far since we've been recording. So
Yeah, yeah. So I did that for a couple of years on my own. I
Mhm.
had my first son, and then just through some personal circumstances, that schedule of kind of, because it's a tough schedule. You're up kind of most days
Yeah.
working at 6 a.m. to 10
Yep.
a.m., 11 a.m., have a bit of a break, and then you go
Mhm.
back in the, evenings. So that
Mhm.
split schedule just wasn't quite working for me anymore. Um,
Mhm.
and so kind of from there, I was needing more of a 9 to 5, Monday to
Yep.
Friday traditional work
Yep.
schedule. So that and my only other work experience at that point was clinical research.
Yep.
So that's kind of how I led into my role at PHR, got led into my role at PHRI,
Okay.
which stands for Population Health Research Institute.
Yep.
And it's a separate sort of research building on the campus of the Hamilton General.
Yeah.
Yeah.
The now uh, it's that sounds to me, especially when like you population health, like, obviously, maybe whoever's the primary is a little bit more of an epidemiologist, but it actually
Yeah.
sounds like that would be a good role for somebody who has that CEP type background, because you're actually better at fitness testing, so to be able to gather some information about health status, that fitness testing background, even if it's just familiarity, is probably really useful.
Potentially, I think it depends up on the project or the
Yep,
study that you end up on there.
yep,
For me, it was less so, because
okay.
I ended up on a drug trial, which
Yeah,
in and of itself was very interesting. But having the background and, obviously in kinesiology, health science, and being in that world, was very helpful. Obviously, I understand the language and the
yeah,
terminology, lingo, and I had the
yeah,
background in research.
yeah,
So
yeah, absolutely. Okay, and then so like you say, it was a drug trial. How long were you there for?
I ended up there just for a couple of 2 years,
Okay.
because at that point, that's when I applied to osteopathy school.
Awesome.
And then kind of at the same time that when I first started osteopathy school, I thought I was going to be able to keep my job at HHS,
Uh-huh.
right? They always say, oh, you
Mhm.
can work during, and so I had worked out with HR kind of a reduced schedule, and
Okay.
then I got into first year at CAO and
Mhm.
very quickly realized that I'm not going to be able
Okay.
to do both and keep my sanity.
Yeah.
So at that time, I ended up finding a position with Wellspring Cancer Support Foundation.
Okay.
And so while I was a student at CAO, I ended up working with Wellspring, and I was in charge of facilitating their cancer exercise program, both
Oh,
at the center,
okay.
and also their community-based program for graduates of their cancer exercise
Mhm.
program was 20 weeks. Then they didn't want to just kind of boot people back out into the
No.
community, because,
Uh,
for various reasons, there's
yeah.
barriers for them afterwards as well. So
Oh, yeah.
then we had a program, at the YMCA in Oakville, where
Okay.
graduates of our exercise program at the center could come, and then I would help them kind of get reacquainted with,
Mhm.
community fitness.
Oh,
So I
that's
did
awesome.
that
Okay.
for right up until the pandemic.
Yeah.
Yeah.
Yeah, yeah, yeah. When did you finish up your schooling or
Um,
your osteopathic schooling?
yeah, I started in spring of 2017,
Mhm.
and then I had my second child right after third year, so I took a 6-month
Okay.
deferral, which coincided with the beginning of COVID.
Yeah.
So that I didn't end up finishing until the fall of 21.
Okay. Right on. So you've been in what we could call, say, live practice since 21.
Yeah, I took a few months to kinda recollect myself and figure things
Alright.
out. Yeah,
Alright.
I started kind of beginning of 22, I would say.
Okay.
Yeah.
Okay. So now we have you as a fully fledged osteopathic practitioner with a background in clinical research, a background in exercise physiology. The where have you been working? Like, so are you in Burlington? Are you in multiple locations?
Mhm. So, my primary clinic, I would say that I've been with the longest is, located kind of on the border between Oakville and Burlington. It's a physiotherapy-owned clinic.
Oh,
So I
yeah.
work with a lot of pelvic floor physios, ortho physios,
Okay.
RMTs, and myself are there.
Uh-huh.
I did spend about a year working out in Fonthill, with a
Yep.
graduate CAO graduate
Yep.
who she's focused on pediatrics.
Yep.
I was really interested in, because I had just been through it. I have 3 children now,
Yeah.
so I
Yeah.
was really interested in kind of working with the postnatal, like pre and postnatal
Mhm.
population. So I did
Mhm.
that for about a year.
Yep.
Commute got to me. So recently I've started at another clinic here in Oakville. So I
Okay.
spent my time between 2 clinics. Yeah.
Awesome. At the moment, so with that experience, so if I'm not mistaken, that was, Best for Baby
Yeah.
and
Yeah.
Joanne. So Joanne was actually, like, I was a classmate of hers, so I know Joanne.
Yeah. She's lovely. Yeah.
Yeah, absolutely. I think she was I don't know if she was a radiologist or, like, or a
Has
radiology
a
tech.
medical background as well, I
Yeah.
think.
Yeah, yeah, yeah. But yeah, she's got the pediatric focus. Now, as it stands, are you sort of aiming more at that pediatric and prenatal? You're just treating whoever comes in?
Currently, yeah. So I
Okay.
did like working with that population.
Mhm.
There are some challenges with that population in terms of just, they're busy,
Yeah.
they're not prioritizing themselves. They kind of come in, get a few treatments. I did use my exercise phys background with them, and
Okay.
even just my own knowledge of kind
Yeah.
of helping people reconnect to their deep core muscles and how to
Uh-huh.
help heal
Absolutely.
diastases and turn their glutes back on and all those kinds
Yeah.
of things. So I would
Mhm.
kind of marry that into my treatment there. I
Mhm.
enjoyed that, but I feel like I'm still so new to the practice of osteopathy that
Okay.
I like the breadth of experience and
Yeah.
just seeing a wide variety
Absolutely.
of clients in a bigger population. Yeah.
Yeah. So, what was it about osteopathy that sort of got you interested?
Oh, it's a loaded question.
Okay, so what was the experience that introduced you to osteopathy?
Yeah, so I first heard about osteopathy after I basically blew up my ankle. I had an ankle injury.
Okay.
and it just wasn't getting better. I was doing physio, shockwave therapy, like acupuncture, right?
Yep.
And it just wasn't getting better. It's my right ankle. So, I was in my late 20s at the time. I was having a hard time walking without pain, driving without pain.
Yep.
So it was impeding on my life, especially as a very active person.
Yep.
And finally, the physio that I was seeing said, "Oh, you should go see this osteopath." And I'm
Mhm.
like, "A what?" I had never heard of it.
Yeah, yeah.
Um, I went to see this guy. He was very quiet. He did a bit of a standing assessment, got me on the table, and worked on my pelvis. Didn't even touch my ankle.
Mhm.
And I was like, this guy knows I'm here for my ankle, right? Like, you know what I
Yeah,
mean?
yeah,
Like, I
yeah, yeah.
didn't say anything, but I'm like, okay, like I don't know what this guy's doing. But then my ankle started to feel better.
Okay.
And so that was kind of like, it was like that was very interesting to me because, up until that point, it was like, you hurt your ankle, you go get your ankle
Yep.
fixed. The
Absolutely.
person's gonna look at your ankle. So that kind of planted a bit of seed with me. And that was actually during my time at Sick Kids. And so then osteopathy just kind of weaved its way into my life in a few different ways after
Mhm.
that. When I
Yeah.
was at the gym doing personal training, one of the guys that was coming in for kickboxing was an osteo. And so I started
Oh,
referring a lot of my clients to him because,
nice.
there was things I was seeing as a trainer or struggles that my clients were having that I just didn't have the knowledge to help them with. So
Mhm.
I would refer them out to him. He would work with them, solve a lot of the problems. I was working with them in the gym, and we were
Mhm.
getting like really beautiful kind of synergistic results because
Awesome.
clients were doing both things.
Yeah, yeah.
And so that really, really, I would say that experience is what really got me thinking, "Oh, I want to do this. I need to look
Yeah.
into this seriously."
Awesome.
So,
Okay.
yeah.
And then you kind of scoured around for schools. You chose one and went ahead and did it.
Mhm,
Fair
mhm,
enough. Like the with respect to say, this is just me trying to connect some concepts. So, it is relatively common with patient experience with osteopathy. And sometimes this is really just how the practitioners look at it, not necessarily how it actually works, but some people do it more as a sell job and other people do it because it's what they fundamentally believe. But the concept of you have a problem, you have a problem here, but somebody works over here, right? And then this problem changes. So there's different ways to try to explain that. Like, so your ankle's got a problem, so somebody works in the region of your pelvis and your ankle changes. There's lots of fancy ways to try to explain that, but the basic concept, at least the way that I would try to pull way back to kind of what I would call foundation, is osteopathic practitioners work on movement, period. So they do movement tests. Either you move a whole region in a macro sense, and there's smaller problems within it, or you squish soft tissues, and it either squishes or it doesn't. Like they're all motion tests. So whatever isn't moving is what I'm going to work on because my scale as a practitioner is the motion scale. The patient scale is the sensation, right? So uh, osteopathic practitioners work on signs, which is what anybody can identify, including the patient, whereas patients really their scale is the symptom, which is essentially what only the patient can identify. So a runny nose isn't a symptom, it's a sign, right?
mhm,
As just kind of me trying to uh, encapsulate this. So what was probably happening, at least in your case, if somebody was to look back at it with a different view, is that, yeah, sure, you definitely blew up your ankle, but the thing that wasn't allowing it to get better was the fact that you were unevenly distributing load somewhere else, right? And you can talk in all kinds of fancy ways, use all kinds of concepts, but it's like it just didn't move there. Like right there, if I work on that, we're good to go. The problem that I think I run into with respect to the profession is when people say it's got to be this thing, right? It's like it's always the pelvis.
mhm.
If you think it's always the pelvis, then it's always the pelvis. Did you check everything else? Right.
Mhm,
So as far as practice is concerned, it's one of the reasons why if people choose to look at a bunch of the technical stuff that I have up, it's why I say, you check everything. You just check everything. Whatever's not moving, that's what I work on. If it's appropriately related to the thing you're feeling, they'll change together. If it's not, well, at least that's moving better.
Yeah, yeah. It's no, like, no harm, no foul, right?
Yeah. Oh, and like I helped you, just not the
Yeah,
way you wanted me to.
yeah, yeah.
So yeah, the that experience is relatively common. I don't know if you've experienced this yet, this general story that a patient will come back with. One of the things is this usually the second time I see a patient what they'll do is they'll tell me, "Yeah, I told my friend I saw you, and they asked me what you did." And I said, "I don't know, but I feel different." Have you heard that one yet?
Yes.
Yeah. And it's a lot of it is because we're on the more subtle side as far as how we apply movement. But I mean, you've worked in the health space for a long time. You've had a lot of different treatment, it sounds like. The movements that osteopathic practitioners do are not that different. Like it's one person moving another person. So the movements aren't that different, but the manner of application is different. And I tend to claim it's guided by the barrier concept. Just don't make them say ouch. So if you're
Mm.
following that, then yeah, it's a little bit more subtle. It's not spectacular. Okay. Now, the question that I really wanted to try to dig into for you is because you're in clinical practice, you have this research background, you have this exercise physiology background, the training background. In what way, and maybe it's a broad question that we can try to narrow in on, but generally speaking, is there a way in which that exercise physiology background impacts or guides how you work through clinical cases?
I think, I mean, when I always go back to my osteopathic principles, and that's always where I start. And that's what my hands are informing me as I move
Yeah,
along. But then in some cases, um, it's more about what I'm then how I'm mirroring in that background for like recommendations
sure.
maybe for
Okay.
someone. So for example, I have a woman who has quite severe swelling and edema in one of her lower limbs.
Mhm.
She's clear for treatment.
Yeah.
But what
Excellent.
but what I've been doing from an osteopathic perspective, obviously, is working all the diaphragms,
Mhm,
drainage points, pinch
mhm,
points, any soft tissue
mhm,
restrictions throughout that
mhm,
pathway.
mhm.
And then the way that, my recommendations to her after, obviously walking is good, but then,
Yeah,
things like hip circles and things that are going to
yeah,
get the lymphatic system moving through the groin and
yeah.
some diaphragmatic breaths, arm
Mhm,
swings, things that are just thinking about pumping that lymphatic system. So that's
yeah,
osteopathic, but it's also,
yeah.
a movement recommendation. So
Sure.
that would be an example of how I've started to kind of weave that in
Yeah.
for her, or, people I've treated people that come in with their primary complaint is like they have a diagnosis of hip osteoarthritis.
Yeah.
So I'm working with that, but then there's some strengthening, and stabilization things that we
Mhm.
can work on that I'm doing.
Absolutely.
So, that's kind of how I've tried to weave it in.
So, would it be fair if I say that even if somebody's using, say, a more active approach, like a patient active approach on the table, there's only so much you can do within a given time frame, and the habits of the patient outside the clinic room have an impact. And because of your background, you might be more more accurately able to identify where what they do outside of the treatment room could be impactful.
Yes, and I
Okay.
and I think I saw that from the other side when I was doing the personal training piece with
Mhm.
people at the gym and sending them to the
Yeah.
osteo,
Yeah, yeah.
right? And we were seeing that nice result. So now it's like, okay, now I'm in the clinic
Mhm.
and I know what I'm doing treatment-wise with someone, and I can kind of understand what I think they need to do outside of
Yeah.
our treatment sessions that are gonna then, get us a little bit further or help
Yeah.
things hold a little better.
Yeah.
And so that's kind of where then my recommendations lend itself to that. And it's certainly not every client wants that or is looking for that. Some
Mhm.
clients are, you know,
Yeah.
um, right? It's just like some people, adherence is not going to be there. But
No.
I also believe you kind of have to meet people where they're at. So
Oh, 100%.
I have a handful of people who I work with who, are quite overweight. They've got, their various complaints that they're coming in. We're working on finding the health and improving that, osteopathically on the table. But then
Mhm.
we're talking about like, okay, what's your baseline walking,
Yeah.
oh, you're type
Yeah.
2 diabetic. Did you know? And I inform them about, if you're walking for, I think research shows even as little as 2 to 5 minutes post meal, that can have a positive
Yeah.
impact on the blood sugars, right? Because
Yeah.
we're regulating those GLUT4 proteins. And so
Yeah.
I explain that to them. And then, okay, let's get a baseline for your walking. Okay, let's figure that out. And then I want to figure out like, okay, what's your barrier? Like what makes you stop walking? Is it
Mhm.
that your hips hurt? Is it that your back hurts? Is it you're out of breath. Like,
Mhm.
what is it that's stopping you? And then how can I help support that process so that we can actually increase your walking ability?
Mhm.
So I've worked with people that way,
Okay.
and that's kind of an adjunct onto the osteopathy sessions. But at the end of the day, like if they're coming in because their hips hurt when they walk,
Mhm.
okay, is that a muscle fatigue and endurance issue, or is that,
Yeah.
a mechanical issue that I need to help them with on the table, or is it both, right? So
Yeah.
I'm trying to tease that out with
Sure.
people, and then kind of go through that sort of progressive overload with them, or some of the strengthening, or
Mhm.
or is it a cardiovascular issue, or
Yeah.
what have you? Or all of the above. So that's
Mm.
kind of how I'm
Okay.
working with people.
Well,
Yeah.
it sounds like based on prior knowledge, you have a few more things that you can attempt to pick through. So you can make a broader hypothesis and say, okay, if I do this thing, it should do this. And if it doesn't, then it might be one of these other things, right?
Mhm.
So have you possibly, I really, I don't expect on any level that you would have come across this. Have you heard of the theory of constructed emotion?
Can you explain it to me? Maybe I have, but maybe not that term.
It's okay. It's fairly new in its formulation. The woman who put it forth is Dr. Lisa Feldman Barrett. And one of the reasons I like her, well, two of the reasons I like her, she's from North York. So, does Young and Steeles make sense to you?
Oh yeah, yeah.
Yeah, she grew up around there. Older than me. I have no reason to think that I know anybody who knows her. But she also swears in interviews, which I really like. She's she's in Boston, if I'm not mistaken. But anyways, essentially what she is suggesting is that there are words there, so they're category words, right? So anger. And
Mhm.
then if you, no matter what you want to measure, you're going to have a variety of presentations that people would ascribe to that word, right? So you take one of her more well-known, or one of the essentially examples she uses is a scowl. So in North American culture, at least, when somebody's scowling, you would begin to assume that they're angry, right? Or they're experiencing a negative emotion. So it's about 30% of the time somebody's scowling. Upon examination, they're angry. 70%, they're something else. So I'm fairly facially expressive. I make a lot of interesting faces. I know this about myself. So it's really easy to misinterpret because I might just be thinking. And realistically, if I'm making funny faces, I am thinking. But funny enough, it's not necessarily in words in my experience inside my head. It's just so the sounds I make outside are the sounds I'm making inside. I don't have a lot of what I would call consistent internal monologue. I just
Mhm.
don't. I
Mhm.
probably used to, but it's so far in the past that I don't remember it. But anyways, so there are obligate physical sensations that you will experience, and then it will go through interpretive filters,
Yeah.
right? So a novel sensation that would be considered negatively valenced or in a negative direction, it is uncomfortable. You would normally pull away from it. When it's a new sensation, it's you probably don't never saw Sanford and Son, did you?
No.
Okay. Have you heard some like or seen somebody go like, it's the big one?
No.
Okay, don't worry about it. It's from the 70s. It's before my time, but I know it. But basically, like the modern example would be on Google when somebody looks up their symptoms and it's
Mhm.
clearly cancer. Like
Mhm.
everything's cancer.
Yeah.
It's sort of like that. So the internal experience is the novel sensation is a problem. So one of the things it sounds like you might be running into, or to add into your pool, your hypothesis pool with these patients, is the thing that gets in their way is that physical activity is obligately, in an obligate way, it is physically uncomfortable, especially when you're not used to it.
Yeah.
And so you're sore when you're doing it because it's a new sensation.
Yeah.
You're sore when you're done,
Yeah.
right? So clearly, yeah, like I'm not supposed to do this because it's sore. It's like, no, it's delayed onset muscle soreness.
Yes.
If you adapt to it,
Yes.
then you can work with it. This is actually something that I learned because I'm a big dummy.
Yeah. Well, it's having those conversations with people too about like having them distinguish the difference between discomfort and
Mhm.
pain,
Yep.
what's okay, what sort of sensation is okay to
Mhm.
continue, what kind of sensation is not. And also that I think one of the physios I work with, she's really big on pain neuroscience. And so
Yep.
it's about like having people understand that pain is not inherently bad and
Mhm.
that it's not necessarily causing damage to your body, right?
Absolutely.
Like I think a lot of people think, oh, I feel pain, therefore this is causing damage. And so
Yep.
it's just having those conversations and with people to help them understand that, right?
Absolutely. So I think the way that the theory of constructed emotion does a good job of this is because it is kind of a neuroscience thing where you have sensory surfaces in the body. They deliver information and then you interpret. So that information, when novel, you don't have an interpretation for it, but you
Yeah.
compare it to other things that you think are similar. So
Hmm.
now it's pain. It's like you're not understanding. It's just challenging. It's so the difference, I would say, really roughly, the difference between pain and discomfort. Discomfort is negatively balanced. You don't like it. Pain means you cannot continue,
Yeah.
right? Like it's just you're done.
Yeah.
Uh, now, I would suggest most people are never going to be really familiar with that because they don't do things at the edge of their physical capacity, right?
Hmm.
Like I sprint, I'm not good at it, but I sprint. So I know exactly what it is when it sucks or when I can't,
Yeah.
right? When I exercise, generally speaking, I like things to be difficult and over. So I say I sprint. People are like, oh, you like running? I'm like, no. Like, what do you mean? You run? I'm
Yeah.
like, no, no, no. I like it
Terrible, but I do
difficult.
it. Yeah.
Like
Yeah.
I like difficult and over. The best part about a sprint is it's over,
Yeah.
right? So when I lift, I prefer to lift heavy or lift towards failure. Like I want to not be able to do it.
Hmm.
But obviously there's safety concerns there. So you learn that. But you learn that sensation. You're like, oh, I really can't do anymore. So when my friend is spotting me on say on bench press, he's like, literally everything looks fine, and then you can do nothing.
Yeah.
Because
You just
I don't have that. I don't tend to have the degradation in performance, but I know that about myself. It's like I'm going fine, and then I'll literally fall over.
yeah.
Like it's just done.
Yeah, and I think I mean, that's true. A lot of people that we kind of come into clinic, not always, but at least the population that I tend to see, they're deconditioned, right? So they just don't
Yep.
have that knowledge or that
Yeah.
experience. And so it's
Yeah.
about having those conversations and educating them.
Yeah. And that is something where experience helps you talk about it, but also to get them into experiencing that is challenging. So this is where the determinants of behavior change, which is
Mhm.
probably something that you would have gone through
Yep.
get like in university, and to recognize, oh, getting somebody who doesn't exercise to exercise is is
Yeah.
insane.
And that's not well, I mean, you have to meet people where they're at, right? Which is why I don't
Absolutely.
always
Yes.
work it into my practice. And,
That's
and I also recognize that there's only so much I can do in the clinic now in the
mhm,
role that I'm at. So,
yeah.
if I do have someone who is kind of taking what I've given them by the reins and they're going with it, then
Mhm.
that's when it's best to, I'm still actually looking for someone great in the community that I can refer out to
Mm.
because there is just more that needs to be done
Yep.
that we can't do. And I did have that when I was in Font Hill. There was a lovely young girl who was very, educating herself and well versed in postnatal fitness. And she was
Yeah.
sending the right messages. She was working appropriately with these women,
Yeah.
because not all of them do it, right,
Right.
she was progressing people properly, so
Mhm.
it was great to have that resource
Mhm.
outside of the clinic where it's like, I can get you started and I can
Mhm.
start your foundation for you, and we can have some of these conversations, but at the end of the day, if you're really wanting to make this change, this is kind of the person you need to see for that, and I'll continue to work with you in the clinic on,
Yep.
the things that we're working on.
Yeah. Well, I think the place that we as professionals have the highest yield is those things that you can't get moving yourself, we can help you get moving, right? And we
Mhm.
can do it in a subtle way. So the way that I tend to explain it with respect to osteopathy versus other healthcare practices is osteopathy centrally avoids the pain response on purpose, where other
Mhm.
hands-on professions, they're not trying to generate a pain response, but they don't mind it.
Yeah.
Like they just don't mind it. So for those people who mechanically can improve in the presence of the pain response, almost anybody can do that. We're the ones who are going to get those really weird results for those people who we are able to avoid the pain response for.
Mhm.
And maybe it's everybody, but if you can improve with almost any hands-on practitioner, then the osteopathic practitioner is not going to be somebody you seek out eventually. The so we can our end range is if it can be done on the table, and it can be done without the pain response. We're the thing that's going to help you progress the best that way. But at a certain point, we run out of space and room for improvement because we did what we were supposed to do. Now that person, through habit, has some stuff to do. The challenge becomes psychologically that you're a little bit more likely to run into, as a patient, somebody with a stronger external locus of control. So they think their actions don't impact their outcomes. Like, it's not that they actively think that, but you can observe that through how, it's somebody else's fault. Somebody else should fix it for me, right? So people who do better with a trainer are people who say, I need somebody to guide me, right? Now, it's not negative. It's just kind of how somebody's wired up or how they think. Whereas people with a stronger internal locus of control who think my actions
Mhm.
are going to impact my outcomes are the people who are a little bit more likely to get themselves in trouble, but then try to figure their own way out. So they're less likely to show up. So, the reason that I say I understand getting to a physical limit because I'm a big dummy is because I like to go hard, and I usually can, whether I'm conditioned or not. So it's why I understand to some degree that people who are not conditioned can express their strength. They just don't recover well. Right? Like they will eventually if they keep doing it. But it's those things where, all of a sudden out of nowhere you have to paint. You have to paint the house. Well,
Mhm.
you're going to be sore.
Yeah.
Right? Now, if you're in generally good shape and regularly exercising, you're probably going to be sore for a smaller amount of time.
Mhm.
But, the because you can do all those things. None of those things are physically taxing as an individual thing. It's just the repetition. So you should get sore from it. So anything that you do on purpose should make you at least a little bit sore physically. It's a question of, are you used to that? Do you know that you can perform in its presence? Do you know that it will go away? Because if you don't know that, it's cancer. So I mean, I think you're a good example of being able to identify in a meaningful way from both angles where one of your skill sets runs out of steam,
Mm,
right?
mhm.
It's like I can do this with this skill set, I can do this. With this skill set, I can do the other thing. And you have experience with it on both sides, as you noted.
Yeah.
Yeah. So the hmm, in the Burloak area, I mean, like I live in Burlington, but I don't have much of a network here because I've always been busy with my daughter and doing other things. I'm sort of surprised that it's not obvious who the general training population or the general population of trainers would be that would be appropriate for you to send people to. That's interesting to me because there should be a few.
I'm sure there are. To be honest, I haven't actively sought it out. So that takes time and effort and energy too.
Yeah,
I'm very careful about who I refer to. So
absolutely.
right. So I have a number of good RMTs, for example, because our clinic RMTs are very busy. They don't
Yeah.
take, they're not taking new people. So I do
Mhm.
have, a handful of external RMTs that I will refer to, but I won't refer to anyone unless I've been to them personally for treatment. We've had a
Yeah.
chance to talk and all of that. So, it just comes down to a matter of prioritizing and making the time to go out in the community. I'm sure it would be fruitful for me as well as a practitioner because then the referrals can go both ways.
Absolutely.
Um, but yeah, maybe I'll put that on my docket.
Well, what I would say for you is you have children, you have a practice.
3 of them. Yes, it's busy. Yeah.
Yeah, you actually have to pay attention to what's going on. So the eh, I have a similar experience. I only have one child, right? But
Mhm.
my prioritization of her above the other stuff means that I haven't necessarily been able to build a robust network in any one location. I've had to rely on the networks of others on that level. So yeah, I get it. Does CSEP maintain uh, a listing of people with the CEP? Like, is that on their website?
There is a membership directory,
Okay.
so I could go in and see if there's people in the area,
Mhm.
because that's always the concern. I think a lot of trainers now will have their bachelor kin, which is
Yep.
good. It's better than, like a CanFit Pro or what have you. But,
Yeah.
really like working with special populations is a different thing. And I need to know
Mhm.
that the people that I'm referring to have that extra knowledge piece or even post grad work, with
Yeah.
through the continuing education that's required. even like recently, I've also gotten a few people who have been through a cancer experience and
Mhm.
are having some difficulties, post radiation and things like
Yep.
that. So they're for treatment, everything's fine, but they're now having some other related issues. So I'm working with them on the table. I'm giving them
Mhm.
some recommendations, but they don't maybe necessarily qualify to be at Wellspring.
Okay.
But there's people I'd love to find a place in the community to
Uh-huh.
maybe send them if they're
Yeah.
needing that.
Yeah, and like me just asking about the member directory, like one of the things that's interesting is just because somebody has a title attached to their name doesn't mean they're the same.
Hmm.
Like it doesn't. So like like having a bachelor of kin, like whether regardless of what kind of bachelor, the different schools have very different curriculum, right?
Hmm.
Because it's dictated much more by the research interest of the faculty, because they're going to teach on what they want to teach on, right?
Yeah.
Or like what they're capable of teaching on. So they're if somebody's got on our kin, then you know that they've had a board exam. But that board exam doesn't predict how they work, right? It just means that they could pass the test, right? So I happen to be relatively interested in assessment type processes because of my master's in health science education as well. So it's like, I don't know. Just because you passed one test doesn't mean much to me. But at least the CEP, because it is an organization that you have to maintain your qualification to use the title.
Yes.
Yeah. So there
So
is consistent activity. And is there some form of interspersed assessment of your skills?
there's not.
Okay.
So I've had my CEP now for, I don't know, since 2009. So
Mhm.
we're going on, what is that, 15 years?
Yeah,
Uh,
pretty
yeah.
much.
Oh gosh. So yeah, I mean, we have to maintain our continuing education credits. It's
Yeah.
a 2-year cycle, right, that we
Mhm.
submit. We have to keep our first aid and CPR
Yep.
current yearly.
Mhm.
So I renew that yearly.
Mhm.
Um, and then of course our liability insurance we renew on an annual basis as
Mhm.
well.
Yep.
So I mean, there's post grad education that we're doing, but there's no check-in. I was audited. I've been audited just once
Okay.
in terms of my submission for my education
Mhm.
credits.
Mhm.
But yeah, there's no continuous. I mean, a lot of the skill sets I would say, like I've even probably lost, right?
Sure.
Like, I haven't conducted a VO2 max test in a
Mhm.
very long time, or
Mhm.
taken an exercising blood pressure in a very long time.
Yeah.
Is that a skill I could easily regain? Yes, but is it valuable to me at this point? Probably not. Like,
Yeah. Fair enough.
yeah.
Well, at least with respect to say something like an exercise blood pressure, that's much more of a lab skill.
Sure, yeah, right. And
I would call that
I'm
a
just not
lab skill.
working. I'm not just not working with people in that way, right?
Yeah.
So it's
Yeah. Yeah.
not really relevant to
Yep.
what I'm doing.
Absolutely.
So
Okay. Yeah, this is interesting. So I think the model for me, or the way that I would try to understand how you would end up approaching a patient, is that you recognize, as I already noted, the barrier, or not necessarily the barriers, but where each skill set runs out of steam. So where each skill set is strong and very useful, and then it's like you need this other thing too. So say in terms of insight, you may have more detail-oriented ability to identify it. It's like, okay, this is where this is going to do really good. Okay, we did really good. You need
mhm.
that.
Yeah, so it's kind of an example, like another case study, or case patient that I had
Mhm.
within the last couple of months was a young man who was an athlete, and he had, I know we can't diagnose, but let's just say, well, it was a bursitis of the pes anserine, right?
Mhm.
So he's like, my knee really hurts. This
Mhm.
this kind of thing goes up and down. No one else been able to fix it, and I'm like, all
Mhm.
right, so we get in there and we assess. I've never seen someone with so much, like restriction in like the adductors and
Mhm.
the semitendinosus, membranosus, whatnot. So get in there, did my thing as an
Mhm.
osteopath, right? Or ONP,
Yeah, osteopathic
to,
manual practitioner. Yeah,
yeah,
yeah. The
as
law.
yes, not get myself in trouble here. Did what I could on the table, through MFR, PIR, RI, all of the skill sets that we have. But I said, this guy is training 5-6 days a week intensely. This is not going to go away with me
Mhm.
treating him once a week for however many weeks or whatever frequency we decide is best. Like I said, the reality is that you need to do X, Y, Z. Here's some dynamic things you need to do
Mhm.
before you train. Here's some
Mhm.
static things you need to do
Mhm.
after each training. This is what you need to do in between.
Yeah.
And we were successful at resolving that for him. So, but he was disciplined, and I told him, I was very clear with him, you need, like, seeing me is not enough. You need to be doing this in between.
Yeah.
Otherwise, this is not gonna, I'm not gonna be able to help you either. Like, and to his credit, he was diligent at doing that, and we resolved the problem. But, I think that's a perfect example where you said, I understood, like, what can I do for him on the table, and balance out some other things that were impacting that as well throughout the entire chain and whatnot. But then also, okay, but realistically, because you're training on a regular basis, this is also what you need to do. And that's where the XFIS kind of piece came in.
Yeah, that's awesome. Okay, so I don't have any other specific questions for you, because I think that does a really good job, and I appreciate it, because one of the reasons I was interested in when I saw CEP attached to your name, I was like, a real one. I found one in the wild.
We do exist. I don't know how many of us there are, probably a few, but maybe not that many, maybe more.
And they probably almost all went to York University.
I'm sure. Yeah.
But it's because I think isn't CSEP located in Ottawa though?
Yes, head office.
So there's some other stuff, because there's probably some other schools that they run some of the program through, or like at least the ability to qualify to challenge the test. So there's probably some other locations, but yeah, it's, as far as I can tell, it's kind of Ottawa and the GTA where you would be a little bit more likely to find them. But that's also because those are the two of the places in Canada that have actual population. Most of the country doesn't have much of a population, so fair enough. So I'd like to say thank you for the discussion. It helped me a lot, and it helped me kind of build out a conceptual model that allows me to say, yeah, you recognize where the skill sets are strong. So I think with my personal experience as a kin, working in the active realm previously, with my experience personally exercising and knowing what that's like, and the normal thinking problems that happen to people who like to exercise, you have it more, I would say, more formalized, because you actually have the training with special populations on the exercise side. So that helps me. So what I'll do is I'll say thank you, and then I'll stop the recording, and then I'll say a proper goodbye after I stop the recording. Okay, so thank you so much. And also,
Well,
if people want to find you, Burloak region.
Yeah, I don't know if you want specifics but what.
Oh yeah, tell them.
Yeah. So my one clinic is Healthy Balance Physio and Wellness. We're at Great Lakes and Rebecca. There's a little plaza there with a really good new coffee shop, by the way, and it's called Coffee. It's amazing. So shout out to local small business, but if anyone likes good coffee, they're delicious.
Nice.
It's really good. And my other clinic is called Mobility Plus, and we're just at the QEW and Ford Drive.
Sweet. Okay, perfect. Thank you. Here we go. I'm gonna stop the recording.